Anesthesia
So
for
my topic
carotid
is on
endarterectomy.
anesthesia for carotid endarterectomy. Yes, sir.
Yeah, go ahead.
Yes, sir. Carotid
Have you given
endarterectomy is
anesthesia for a case like this, Jaya Bharathi?
I have assisted once, but very long back after joining here. I didn't get a chance. Only 2 cases, and that also was in another OT, so I couldn't.
Okay. No. Did you give GA or was it done under local and you just had a monitored
It was
anesthesia?
done under both superficial plexus block plus GA, sir.
Okay, okay, good. Go ahead.
Both the cases were done under block plus GA, sir.
Okay, okay. Right.
Okay, sir. So that's why I wanted to read about this topic in detail, sir, since I have not done. So
Okay,
if
okay.
it comes in exam, I should be thorough with it. Okay, sir. So carotid endarterectomy is a surgery done in patients with thromboembolic or obstructive atherosclerotic lesions in the area of carotid bifurcations to prevent stroke. It carries high morbidity and mortality. Cerebrovascular events occur due to embolization of thrombus, atraumatic debris, and hypoperfusion, which is secondary to the stenosis. Coming to the physiological effects of carotid artery occlusion, when there is a temporary or total occlusion of a carotid artery, it causes ipsilateral hemisphere, which is solely dependent on the contralateral flow from the contralateral carotid artery. So the cerebral perfusion pressure should be maintained from high to normal, so that the collateral blood flow is sufficient. When there is low cerebral perfusion pressure, there is insufficient collateral blood flow, which can be treated by placing a temporary shunt. So coming to the presentation of carotid artery occlusion, the presentation widely ranges based on the severity. It can be asymptomatic during any investigation of the arterial disease. There can be an asymptomatic bruit or amaurosis fugae, that is transient attack of monocular blindness, transient ischemic attacks, and reversible ischemic neurological deficits like stroke. So, surgical treatment of symptomatic carotid artery stenosis greatly decreases the risk of stroke compared with medical management, and mostly in men with severe carotid artery stenosis, that is about 70 to 99%. Medical treatment include smoking cessation, antiplatelet therapy, aggressive blood pressure control, physical activity, and both dietary and pharmacological lipid lowering strategies. Endovascular therapy, that is emergency angioplasty or stenting, and mechanical disruption of the arterial cross. Patient can be put on antiplatelets like aspirin and clopidogrel, can continue aspirin and clopidogrel during the surgery also, and all anti-anginal, antihypertensive drugs should be continued on the day of surgery. Coming to the indications of the surgery, symptomatic stenosis more than 70% with reversible ischemic neurologic deficit. Stenosis of about 50 to 69% in patients with age of 75 years. Recent stroke within 3 months. And hemispheric symptoms and concomitant intracranial stenosis. Transient ischemic angiographic stenosis. Unstable CNS platelets which persists despite anticoagulation. Coming to the pre-op assessment, 60 patients have asymptomatic coronary artery disease along with the disease. To assess the severity of the preoperative symptoms of both CAD and CVA, age and female sex, increased incidence of serious and CNS complications. Hypertension is concomitantly associated with this disease. Chronic essential hypertension is common. It is useful to establish the usual range of blood pressure for each patient preoperatively to guide for acceptable perfusion pressure. So both blood pressure and heart rate should be monitored purely in the pre-op assessment because it is critical for maintenance of the collateral blood flow. Coming to the investigations, routine investigations like CBC, RFT, LFT, coagulation profile should be done, and ECG to rule out any arrhythmias or left ventricular hypertrophy. Chest X-ray for ruling out of cardiomegaly, pulmonary edema, or any COPD associated with the disease. Doppler angiography, MRI angiography, oculoplethysmography. Coming to the general examination, head and neck and potential airway problems should be assessed. Coming to the anesthetic goals, the main anesthetic goals in carotid endarterectomy should be is to maintain adequate cerebral blood flow, maintain normal BP, PaO2 and PaCO2 throughout the procedure, avoid cardiac ischemia and infarction, ablation of the surgical pain and the stress responses, and to have awake patient at the end of the surgery for the CNS examination. Coming to the anesthetic techniques, the techniques available for this surgery include general anesthesia, local anesthesia, and combined local plus general anesthesia. Local anesthesia includes C2 to C4 segment blockade, which can be achieved by deep cervical plexus block, superficial cervical plexus block, cervical epidural block. Coming to the anesthetic management of the carotid endarterectomy, first the positioning of the patient. The patient is positioned in the head turned away from the right. If regional anesthesia is used, appropriate sedation should be given to avoid anxiety. If general anesthesia is used, maintenance of the hemodynamic stability and prompt emergence of the patient to allow careful neurological assessment should be focused. Coming to the monitors, standard monitors should be addressed, that is ECG, NIBT, ETCO2, and pulse oximetry. Placement of intraarterial catheter also considered. If central venous cannulation is pursued, particular care should be taken that the contralateral artery is not punctured, which compromises the collateral blood flow. Femoral line can be preferred. And placement of pulmonary artery catheter and transesophageal echocardiography can be considered in high-risk patients with CAD. To the cerebral function monitor. Keeping an awake patient is a gold standard monitoring in case of carotid endarterectomy. Some monitoring like a contralateral hand grip, that is, we can give a squeezing toy and ask the patient to squeeze the toy to check the hand grip and observe loss of consciousness and speech assessment and any neurological symptoms occurring. So there should be no neurological symptom after 1 minute of clamping, which indicates adequate collateral blood flow. Next monitoring will be the electroencephalogram, which is the most sensitive indicator of inadequate cerebral perfusion during carotid cross clamping. But with the EEG, only the cerebral cortex is monitored and these structures are not monitored. Any deterioration in the EEG occurs when the cerebral blood flow is less than 15 ml per 100 gram per minute. But there can be any interferences with the changes in BP, temperature, and the depth of anesthesia. So there can also be false negative results in patients with already pre-existing neurodeficits. Next, monitor the somatosensory evaluation. It also evaluates these brain structures. Next, transcranial Doppler, in which the probe can be placed in the petrous temporal bone. It measures the middle cerebral artery blood flow velocity and also the microembolic events. It is used to determine the need for the shunt placement. Next is the carotid artery stump pressures. It measures the pressures in the internal carotid artery once the common carotid and the external carotid arteries are clamped. The stump pressure, which is less than 50 mm Hg, is associated with hypoperfusion. Coming to the steps of the procedure, an incision is made along the anterior border of the sternocleidomastoid between the ear and the sternum notch, and the carotid and IJV are dissected. Wherein 5,000 international units after exposure of common carotid artery bifurcation is initiated. The cross clamping of common carotid artery, internal carotid, and external carotid artery is done. Surgical estimate, depending upon the surgical preference and the estimated magnitude of the cerebral perfusion. Artery repaired directly or with any patch angioplasty. And the clamp is removed sequentially, as it is external carotid artery, common carotid artery, and then internal carotid artery. This sequence is used to prevent any debris from entering into the cerebral circulation. Coming to the maintenance of anesthesia, usually induction is done with thiopentone, propofol, or etomidate in patients with low cardiac reserve. Laryngoscopic responses should be blended along with drugs like xylopar. And cerebral protective measures include propofol or capital infusion along with the volatile anesthetics. Mild hypocarbia is always beneficial. Maintain hypothermia also. Light lanes of anesthesia should be maintained, which permits the EEG monitoring and also maintains the blood pressure in slight higher than the normal range. Nitrous oxide can be avoided if possible as it increases the cerebral metabolic rate of oxygen and increases the metacerebral artery flow velocity. Opioid should be used in small doses to avoid post-op sedation. Parents given the dose of 75 to 100 international units per kg IV bolus before cross-clamping. Is not reversed after the endarterectomy closure. If hemostasis is inadequate, a small dose of protamine 2 mg per kg IV can be given. Vasoactive agents like ephedrine or phenylephrine can be used for hypotension. Something usually requires 10 to 20% rise in mean arterial pressure to preserve the cerebral perfusion pressure. Hyperglycemia increases ischemic injury, so blood sugar should also be maintained less than 200 milligram percentage. And warming of the warm air and warm IV fluid should be used. And confirm the neurological integrity before extubation. So always a wide awake extubation should be done to allow the CNS examination. And hemodynamic control also should be done at the emergence of the patient. Coming to the post-operative management and complications. The immediate post-op, the patient should be observed for any cardiac and neurological complications. Hypotension and hypertension both can occur. Myocardial ischemia, significant soft tissue edema and hematoma of the neck, which can cause skill compression and airway compromise, and any new stroke or acute thrombosis at the endarterectomy site can occur. Hypotension, which is observed immediately after the surgery, can be explained based on the carotid sinus hypersensitivity. Carotid sinus previously, which is sheeted by the atheromatous plate, now will start receiving the blood pressure oscillation and goes through a small period of hyperresponsiveness. So this is the reason for the hypotension. So the hyperresponsiveness to the stimuli causes hypotension, which can be treated with vasopressors and phenylephrine. This usually resolves within 12 to 24 hours. Hypertension, which frequently is observed during the immediate post-op, often reaches the maximum of 2 to 3 hours after the surgery. It can even persist for 24 hours. The reason for hypertension is due to the altered activity of the carotid sinus and also due to the loss of function of the carotid sinus due to the denervation during the surgery. So the hypertension can be managed with the continuous infusion of short-acting drugs like nitroglycerin, hydroglycerin, and labetalol can be used for the BP control. The next complication is nerve injury. So patients should also be examined for the most nerve injuries like hypoglossal recurrent laryngeal nerve and superior laryngeal nerve, because this causes difficulty in swallowing and protecting the airway and can result in the risk of aspiration. And carotid body denervation also impacts the cardiac and ventilatory responses to hypoxemia. So patients should be observed in the post-op with all the necessary monitors like ECG, NABP, SpO2, even in the post-op. And another complication is hyperperfusion syndrome, which is characterized by ipsilateral headache, hypertension, seizures, and local neurological deficits. If not treated, it can also result in SAH and severe brain edema. Thank you.
Did you mention about how to secure the airway for this general anesthesia procedure?
No, sir.
That's very important. And then whether you're going to intubate the patient or you're going to supraglottic airway to prevent the sympathetic response. What are the advantages and disadvantages of each has to be mentioned. And of course, as you mentioned, the anesthesia for carotid endarterectomy can be purely regional in some high-risk patients, or in which some surgeons prefer to do it under regional solely because they want to evaluate the neurological involvement or neurological deficits that can occur during surgery. And the clamping of the common carotid, external carotid, and internal carotid, and opening the artery to remove the plaque has almost become obsolete after the advent of the shunt, which is available. Any idea what is the name of the shunt?
Yes, sir.
Right. So just like the beating heart CABG, which they do with the introduction of a T-shaped shunt into the coronaries to continue with the anastomosis, preserving whatever blood flow that is available. The same technique is now more popular rather than the older method of completely clamping all the three major vessels, depending on the contralateral blood flow. So that has almost been given up in majority of the institutions, and by introducing the shunt, they are able to have a perfusion in the diseased vessel also. At the same time, you are able to comfortably do a plaque excision and close that. And so you have to discuss the answer as surgery done purely under regional technique and GA. And in GA, combination of superficial cervical plexus block will be a multimodal technique of analgesia for surgery to prevent too much of opioid requirement. So when it is done under purely regional technique, there are certain requisites that you have to make sure. So I'll just show what I have prepared.